The Victor Black Masterclass presentation is brought to you by
Okay, Saudi Cup, hello and welcome to another Victor Black Masterclass video. In today's video, I've basically been joined by a special guest, Dr. Adam Hotchkiss. Is that how you pronounce the name, Adam?
Hotchkiss, very close.
Oh, close. I apologize for butchering that.
You threw in the hot kiss, like that's what a lot of people.
Cool. Well, how about we call you Dr. Adam? That'll make my life easier.
That works. Let's do that.
Awesome, cool. And we're gonna be talking a little bit about let's throw the blanket term injury recovery out there today. I was just talking to Adam before the call that I want anyone to understand going into this conversation. I think it's a fair and reasonable expectation that we may well end this call in an hour's time with more questions than we have answers, because this is a complicated subject. I myself would tend to divide this, even as a layman, tend to divide this into categories. I said, okay, so are we talking about wound healing? Are we talking about bone healing? Are we talking about tendon healing? What is the problem that we're attempting to solve here? And each of these areas has the potential to have some crossover where we have some common ground. And each of these areas, has the potential to be unique. And as I even mentioned, in areas like the suppression of angiotensin II, the effector molecule of the RAS system, it's completely plausible that we actually have opposing vectors in some of these discussions. So let's take this call under the banner that says, this is the first call of its kind that I'm aware of in our tribe, where we're talking to medical professionals that are dealing with these types of conditions daily, and we're trying to then match, okay, so what do we have in our toolbox and what do we know from our tribal practices that potentially may act as a preventative measure, or in the sense of after the event rather, a potential augmentative treatment models. So again, first call that I'm aware of this kind, where we're blending the thoughts of the medical professional with the thoughts of the practitioner sort of thing together. So please understand, guys, I think it would be very naive to think we're going to have this call in an hour time, walk away with a prescription that fixes all ills. I think it's just a really interesting thread to pull on. And I mentioned to Adam, if he enjoys the process and people think there's value in it, I could see there's several hours of follow-on dialogue that potentially could happen here. Obviously we'll get an hour in first to see if I annoy Adam enough with my questions. So
no, not at all.
Can you just explain a little bit about who you are, Adam, and your background? I mean, I know you as someone that lifts. I see your fabulous physique that you've developed for yourself on YouTube. I don't know very much about you professionally. Can you give us a bit of a background about both of those things?
Yeah, for sure. So right now I'm actually finishing up my training in foot and ankle surgery. So I'm a podiatric physician here in the United States. I did 4 years of medical school. I'm now in my surgical training and wrapping that up. I have a year left to go. Along with that, I've been training, like doing physical stuff for years now. I actually wasn't really involved with it in high school. I was kind of scrawny little skate punk kid, never thought I'd be where I am now. But I basically found it while I found my love of science through working out. I started working out to kind of change my life for the better. Through that, I wanted to know what mechanisms, what pathways and stuff I was using when I was working out. It really stimulated my love for science. So it kind of just started in the gym, and the gym really led to me moving on and becoming a doctor. So I've done everything, and I've done basic bodybuilding stuff, bro splits, and posing in the mirror to, I did competitive CrossFit for a while, and Olympic lifting and powerlifting. And now I kind of just do a hybrid of everything to try to look decent and be able to move while I age all right. So awesome. kind of a very broad fitness model.
That's great. Something that anyone follows me would have heard me say many times before is I try to listen to medical professionals who are part of our tribe. I think it's very easy to become part of the medical field, to become specialist medical provider, as it were, but not really understand that we are somewhat different to the general public. Do you mean?
Yeah, 100%.
The demands that we place on our body, and the, you know, even the expected performance increases that one would expect to see, especially in the enhanced tribe, things are different. And this is, I guess, the first gambit that I wanted to open up here. I wanted to talk about the differences between natural and enhanced individuals, and the changes in tendon, basically, morphology. I don't know, you're going to have to forgive me as we go through this conversation. You understand very well. I'm a layman. I'm probably going to use terminology. That's the wrong terminology.
No, that's great. Honestly, that's better, I think, for the viewers and everything. I hate tuning into something and like no one knows what this guy's saying, you know. So
we need to use language that everybody kind of gets. I think I get what I'm getting at with this is we know very well that training in the first instance results in changes in cross-sectional area and potential increases in power generation capability of skeletal muscle tissue. This is known. Hello, Captain Obvious. I think what's less well known is the effect that training initially as a natural person, and then by extension, we see in enhanced individuals on what we would call, what I would refer to as, tendons and ligaments and connective tissue. Can you just kick us off by giving us your understanding of, what the differences are there? We obviously see increases in cross-sectional area of muscle tissue. What's going on with tendons and ligaments and things like that as we first become natural trainers and enhanced trainers? Are they affected in the same way? Are they not affected? What's going on there?
Yeah, so I mean, basically, as you said, you lift heavy things, our body adapts, so it builds up more tissue, right? So that happens in both muscles. Obviously, we see the hypertrophy physically. It's happening on connective tissue because the connective tissue or the tendons, the ligaments, things have to kind of they have to compensate for that load. So they're doing their part too and thickening. It also happens to bone. That's called Wolff's Law. Bone will actually hypertrophy and grow. So actually all the notches that you see on bones are because tendons are pulling on them and it grows out. So yeah, it's happening all over. As far as I know, personally, I think that process is only exacerbated or intensified when the lifter is enhanced. I think, and this is actually why I want to talk to you more, because that we don't learn this stuff in medical school. They don't say this is your average person and then this is your lifter or your person on steroids. They don't say it. So, but we do have a lot of those people coming into the clinic, especially in sports medicine and stuff. I'm going to see people who have, leg, foot, ankle pathologies all the time who are enhanced lifters possibly, or athletes, football, soccer, rugby, whatever. Yep. I'm going to see these people and we really don't learn. As far as I know, though, most of the studies that I've seen have just been basically on nandrolone, or as most people know it as DECA, right? Yep. So, I mean, of course, testosterone, but as far as like bone healing and tendon recovery and stuff, a lot of it has been focused around the nandrolone.
Okay. Absolutely. That's why we're here, to drill into that conversation. But I just want to back up a little bit and ask a couple of questions, if I can, whilst we have you to ask. It's my understanding, and believe me, I'm asking, this is a question, not a statement. It's my understanding that women tend not to see as much change to tendon architecture as men do, even as naturals. Are you aware of any structure there? Because I mean, you understand, I'm slowly breaking into helping women, enhance women trainers. My understanding is that men's tendon architecture tends to follow suit with increases in hypertrophic response in naturals, but to a far lesser magnitude than with women. So women plausibly open themselves up to a greater elevated risk of tendon injury when they open up that resistance training door at an elite level. Is that correct? Is that your understanding as well?
Honestly, I don't know. That's something new to me. So that's really interesting, actually. Okay. I hadn't heard that. So, right. I mean, it probably makes sense while you're talking. I'm connecting different pathways and things, and going, yeah, it makes sense. Okay. I understood it. Like
I'll put a study underneath this for what I'm referring to. And again, like to look at that. I always emphasize to everyone, I personally don't believe that you should make grand statements off one study. And I think I've read one study that says this, right? So there may be 15 studies that refute that and I'm wrong, but that's the one study that pops into my mind that says that there is a difference between males and females in terms of tendon-based adaptation to resistance training. So let's get back to that thread that you were saying about, there are some studies on, whether anabolic steroids provide detriment or, benefit to enhanced training. maybe I can give you my take on where we're at with that at the moment.
Yeah,
and then
yeah,
again,
I love that.
any kind of feedback that you want to give us. That so what I would say is that we have these fragments of information that have been available to us for decades now about the potential deleterious application of, or the deleterious effects of the application of anabolic steroids on tendons, and potential elevated risk. What I would say would be this, and that is, there seems to be quite a deal of conflicting information. There is some bias towards like really one drug. I am not aware of any studies that look at drugs in the way that we tend to use them in our tribe, which is not as a monotherapy but as stacked drugs, and the drugs are together typically because they are synergistic and they are beneficial in a stack. So as you said, typically it'd be things like, well, it's just nandrolone, and they look at the consequence of just nandrolone. My personal perspective is, I think it's fair to say that there's two viewpoints. One viewpoint is anabolic steroids consequential to the increase in capacity to create what we call mechanical loading on the muscle. In other words, you get stronger, right? Has the potential to see a consequential elevation in tendon injuries just by virtue of that, without being deleterious in any way. So they're not directly deleterious, but just the simple case of, if you can create more force production through increased cross-sectional area and activation of the central nervous system, it's logical and rational to say, well, if there's a link in the chain that is not accelerated to the same magnitude or at the same pace, it's a potential issue that we would see, even if those drugs are not having a direct deleterious effect on tendon health.
Right. Yeah.
The other line of thought is that they do directly have negative consequence on tendon health. Yeah. My personal opinion at this point in time, and I'm more than open to change it based on new evidence being presented or new studies, because I said that the evidence that we have is very fragmented. My personal opinion is, I tend to lean to the first hypothesis, which
Agreed.
is,
I would believe that too.
okay. Do you think that's a reasonable position to take based on what you've read?
Yeah, certainly. I mean, it makes total sense, right? If your strength is increasing faster due to the muscle growth and the cross-sectional fibers, et cetera, if it's increasing too fast, it's going to put too much load on those tendons that aren't used to it yet.
Yeah.
The only question would be, are they having any effect on the tendon as well? And I don't think it's completely absurd to wonder, if it's growing muscle, is it also growing the connective tissues, the tendons as well? So, of
course, the question there becomes, the paradox there becomes, so by what mechanism would they do that? Because if you can explain a little bit about, how tendons are put together, because at the end of the day, the argument would be, like, in the most simplistic terms, does the increase of muscle protein synthesis, is there a mechanical pathway that logically would increase, collagen deposition?
Collagen, yeah.
So
not many that I know of. So,
okay,
yeah, that would be the question.
Yeah, I guess the information my opinion based on the information I've read is that it's completely plausible that different steroids would have a different effect here. There are a couple of studies on drugs like stanozol that would seem to suggest that is true. There are some studies on drugs like nandrolone that would say, we see different outcomes. So, I would take the position that was said in the first instance, based on cycle selection, it is completely plausible that some cycles put together could potentially cause an escalation in strength through implication on central nervous system, that you might actually say, well, that cycle, by the way it's designed, raises our risk of injury to tendon, because you have this sudden surge of capability the tendons aren't able to keep up.
Yeah, like something like Halo or something like that, right?
Yeah, I mean, I even put Master on that list. Anything that you would basically describe as a drug that has a high mechanical response element, any DHT that has a high mechanical response element, or as you correctly said, Halo test, and any of the drugs that we would typically associate with really not necessarily protein accretion directly, but impact on the central nervous system, I would put into that basket of drugs.
Yeah, 100%.
Okay, so I guess the first thing I would say is, there's a lot of people out there that will ask the question, do anabolic steroids have direct deleterious impact on tendon and on bone? I would say the answer for bone is easy. I would say no.
Right. There's a lot of good studies on osteoporosis.
Yeah,
And
we've
so,
been
yeah,
using these drugs as osteoporosis, treatment methodologies for decades. I think that's well understood. Not deleterious to bone, obviously have positive beneficial effect to skeletal muscle tissue. The big question is, okay, so is it directly deleterious to tendon health, or is it just simply a consequence of increased capacity of skeletal muscle tissue means that tendon now becomes a weaker link in the chain than it would be for a natural individual? So first,
right.
Kabov, you would say that that's a reasonable stance?
Yeah, well, that would be my stance personally. And
Yeah.
that's something that I think the individual could take into account and not go crazy with their training methodologies.
Okay.
Maybe you can bench press 405, but maybe you shouldn't,
And this is going to lead us to cycle design. It's one of the things that I try to explain to people. I don't know necessarily that rapid increases in performance capacity are necessarily a good idea for longevity purposes. I mean, I get it. I'm empathetic, but if you think about it, you go, so if I suddenly go from being able to bench 300 pounds to 450 pounds through artificial means, through modulation of a central nervous system, methodology or whatever like that, then that might not be a good idea if you're trying to avoid getting injured.
Right. Yes.
Yeah. Cool. Can I ask, do you see, I mean, you obviously are someone that trains, and I'm assuming that just by virtue of that, you are like kind of what I would call aware of this. Do you think that people that train experience particular types of injuries to a greater or lesser degree than the general public? Is there a particular, class of injuries go, this is just like something I see over and over and over again in our tribe?
Yeah, things, obviously like the bicep ruptures and the pec tears and things.
Mm-hmm.
I think both have negative. Like, so you can either have the untrained individual who reaches for a bag of groceries and ruptures their bicep tendon because it's so not used, or you have the other extreme where they're using it way too much and they rupture it. So yeah, I don't know if I see more in athletes, especially lifting, who are doing bodybuilding specifically, because I think bodybuilding can be a pretty safe sport. Honestly, it doesn't have to be. It's not like powerlifting or Olympic lifting. Or shouldn't be. That's not to say it is.
Just let me interrupt you there, because I want to. So you would agree that in general, bodybuilding has a different, hours under training to injury ratio to things like powerlifting and strongman? You would agree with that?
I think personally, I think if bodybuilding, if anything, it's more the wear and tear, like on the joints, the cartilage and stuff, rather than the acute ruptures and things like that. Personally. I mean, it should. In my belief, and I'm sure you probably agree with this, it shouldn't be something that you're causing a lot of ruptures and things from. If you're bodybuilding correctly and safely, I don't think you should be loading up and maxing every single time that you go out. That's not the sport. It's like Olympic lifting and bodybuilding, yes, or powerlifting, 100%. They're going for their maxes all the time. Bodybuilding, I don't think needs to be.
Okay, yeah, no, I agree. We're on the same page. So let me get into the body of the dialogue that I would like to have with you, and that is, I guess at the end of the day, there are quite a lot of studies, on various tools that happen to live in our toolbox, that have shown the potential to be, in agents of, improved recovery from injury. I'm just fascinated why we don't see more of the application of those drugs under medical guidance. Like, a lot of this sort of stuff happens in the backyard almost, like, like it's like tribal law, do this and this, but it doesn't, at least through my filters, that doesn't seem to be mirrored in the medical community. Like I said, I can list off a dozen drugs. I go, look, we actually have some pretty good evidence to say that even drugs like clenbuterol would appear to add to, in recovery from injury. Like when you go through them, the anabolic steroids, we know that that's a class of drugs that we can consider. We could talk about growth hormone. We could talk about IGF-1, modulation. We could talk about clenbuterol. We could, and you go down the list, and it's interesting that just on nothing more than a first pass basis, the number of drugs in our toolbox that there is clinical evidence to support some sort of a treatment methodology, a model for burns or for wound healing or for bone healing or osteoporosis or and I find it fascinating that there's such a disconnect between the clinical literature that would seem to suggest beneficial effect for some of these compounds and the lack of the uptake in the medical industry. Can you
Yeah,
can you
same.
tell me why is that? Why is that?
Honestly, I have no idea. And that's why originally I reached out to you. You know, I'm like, hey man, you know about this stuff. And I know about how I could use it in my practice and stuff. And I haven't learned this stuff. Anything that I've learned has been through digging through research on my own. It was never taught to me. I guarantee if I go to any of my colleagues tomorrow at work and bring up something, you know, like clenbuterol, they probably won't even know what that is. They'll be like, oh, you know, was that an inhaler or something?
Yeah,
You
it's
know,
an anti-asthma medication.
yeah, they won't know. They'll probably won't remember it because they haven't thought about that kind of stuff since medical school, just going over basic pharmacology. Things like the BPC, isn't that the one, the gastric peptide, things like that we don't talk about at all. See, I can barely even get them out because we don't use them at all. And I wish that we would. So I'm hoping that, you know, if there's more people like myself and other sports medicine docs and stuff talking to people like you who have used them, even talking anecdotally, at least we can use the anecdotal research, the actual research, maybe get it out in the medical communities. I don't know if it's because pharmaceutical companies don't think there's money in it or whatnot, because unfortunately, medicine money, you know, really.
I'll tell you why I think it is myself, and I'd love your opinion if you could just be straight with me. I'm here to learn as much as anything. Yeah, I have an opinion, and my opinion is the same as hair loss or Alzheimer's disease. And that, in my opinion, a treatment methodology here is going to be multifactorial. If you look at, you know, these various conditions, whether it's wound healing, bone healing, you know, and tendon healing, I think the most logical, rational thing to do would be to go, okay, so let's make a list of potential stimulatory and inhibitory inputs here, and ask ourselves, you know, is there anything in our toolbox over here that could potentially be put on the table under one of those headings? Yeah. And then you very quickly realize that this is not a discussion about a drug. This is not about PBC 157. It's about, okay, understanding what PBC 17 potentially might bring to the table. And it's certainly a very valid and interesting part of the discussion, but it's not the discussion in itself. And that potentially presents problems because anytime you talk about, I'm seeing it at the choir here, but you understand there's a cure to obesity. It's not like we need an obesity drug. We already have the cure. The problem is that you know, multifactorial conversations typically aren't well taken on board by most people most of the time. They're looking for a bullet point cure to something, whether it's hair loss, whether it's Alzheimer's disease, whether it's injury recovery. They basically want, you know, a pill. Give me a pill, doc, give me a shot, sort of thing. And I would argue that at least in my understanding of pharmacology and my understanding of these pathologies and how you would approach it from the point of view of saying, okay, so there's maybe 20 things that we could talk about here. And in my opinion, each one of them brings something to the table, but each individual thing, the magnitude of difference is not great enough for it to be, wow, like there's a cure.
Right. That totally makes sense. Yeah.
So
I
think
things like I've looked into like growth hormone stuff, and specifically in my area of the body, the tibia fractures. There's a big study. I think there was like 400 participants, double-blind placebo study, where they used growth hormone on tibia fractures. It showed something like 26% increase in healing time, which to me that's awesome. And to the athlete, the average athlete, that's probably awesome too. If you can get me back on the field 26% faster, of course. But you tell that to the person who walks in off the street, 26% better, they don't care. It's like you said, we know the cure for obesity, but they want the 100% pill.
They want 100% and they want it tomorrow.
Right. Yeah.
So let's go through, let's start with some of the drugs that we have in our toolbox. Yeah. But before that, I want to explain a phenomenon that I see a lot in our tribe. When someone gets injured, it's really common that guys abandon ship. So they tend to go, like I can't train, and they kind of throw their arms up in the air with despair. And like the first thing that falls away is nutrition. Yep. And I would make a very strong case to say, you know what, like, you know, more than any other time in your career, when you get injured, nutrition becomes paramount. Your body is trying to repair itself at a cellular level, and it literally needs protein and fats and carbs and micronutrients in the optimal ratio to do that. You cannot expect, you know, the workmen to come onto the site and repair the damage to the building if they don't have the supplies, the building supplies they need to do it. And so I would firstly, before we got into this conversation, encourage anyone to say, listen, that's really common in my experience. Guys get hurt and they tend to kind of abandoned ship. What's the point? There's no point in following such a strict nutritional model because I can't train, I can't get my gains. And I would argue this has the, right at first cab off the rank, this has the potential to drag everything out. Now you're just going to make everything longer because your body's looking for minerals and vitamins and essential nutrients to undertake the repair process with, and you're restricting your access to those things because of a dietary practice model. Do you see that when people get injured, people's nutritional behaviors change? Do they get better? Do they get worse in your experience? Is there no change typically?
Yeah, I mean, I deal with basically your average population. So I would say if it's happening in the fitness community, it's 100% happening in our average population. It makes total sense to just kind of fall off the bandwagon. But what you're saying, I don't think we can stress enough. Like all of these drugs, growth hormone, the BPC 57, TB 500, none of them are going to be better than a good, solid nutritional plan, in my opinion.
You have to have the underpinning. Yeah, correct.
Yeah. Like we tell all of our patients who are going into surgery, we high protein diets, and we try to get everything all in line first. Quit the smoking, quit the drinking. All of this stuff affects wound healing, tendon, bone healing significantly. If you don't have enough protein in your body, you're not going to heal a wound. So yeah, that stuff is, I would say, the building block, the most important. And I didn't even think about it, but it totally makes sense. Yeah, guys do fall off because they're thinking, oh, who cares? I can't have abs anyways. What does eating matter? Like I can't work out, so just eat whatever or not eat.
Yeah, and I would argue you should probably overemphasize that at that time. That's the time where you really need to be gold, like weighing shit out. So all right, so the next thing I would ask you is there anything that you would potentially put on the table? I mean, I have my own list of things that you might not do when the sun is shining and the birds are singing, but would make actual sense when you are undergoing injury. I'll give you a couple of examples and maybe you can add anything to your list that comes to mind. I would argue that the amino acid L-glutamine, there's actually a number of very good studies that show potential benefit to L-glutamine under wound healing conditions. I don't know necessarily that I think it's something that you need to take on a daily basis. I think it's a classic case of what the supplement industry very often does is they take studies that show great effect and then they try to say, well, that's recovery, just because it showed, beneficial effect under, these certain wound healing conditions, that means that you go to the gym and you recover. I separate those two things off. I would argue that there are some things that we might consider under circumstances, L-glutamine would be one. Another one would be a discussion around collagen supplementation, even at a rudimentary level, where I would say, today we don't eat meat on the bone. And I would argue that eating meat on the bone, and drawing those connective tissues into your digestive system, there's a plausible thread to pull on there. Now, whether you take it from the point of view of rather than buying your steak as steaks, buy your steak with meat on the bone, so you can basically pull that connective tissue into your diet, or through bone broths and things like that. Now, I think bone broths are a good idea year round. I don't you say you shouldn't do them year round, but I'm saying like it's a lot of fucking work. You're in like, if you buy it in a prepackaged format, okay, great. But it's the sort of thing that I'll be honest with you, there are certain things that I don't do year round because I don't know that I necessarily need them. But if I get injured, I will make the effort. And
that makes sense. Yeah. Yeah, I would definitely say something like that, like the collagens and stuff. Like, I don't really think that they're the catch-all, the optimum supplement, like the supplement companies are making them out to be. They're not going to gut health and all that crap. But like you're saying, in times of an injury, if you can throw it in, even if it's a 5% increase, why not?
So how would you approach it? I mean, I typically would say something like, okay, so step one, buy some meat on the bone. Step two, consider bone broth. What would your recommendation be for collagen supplementation in the context of, making sure that we have that substrate on hand for injury healing?
Yeah, I mean, and like that's the new hottest product, right? There's no lack of collagen supplements on the market right now. In fact, right now in my kitchen, I have a peanut butter that's mixed with a collagen. I don't know what the hell, where they came up with that. It's tasty. But I would say if you don't want to, like you said, it's a pain to cut your meat off the bone yourself, to be your own butcher. So you could probably just get a supplement, and I'm sure it would do just fine if you trust the source.
Okay. Do you, I mean, I've read a number of studies on collagen supplementation, trying to understand, the pathways of administration. Is there beneficial? Is there a large enough magnitude of difference between this pathway and that pathway? My take on it is maybe I'm not sure. Like, if there's so much conflicting information, and I don't think we get at the point where we can say need to do that right there. Do you have the same take? Do you have a more robust kind of, like, I would do this model in terms of?
No, not really. It's kind of, I'm not sure if that's a supplement that kind of bothers me, honestly, in the industry, because it is touted as being like this miracle. And I'm like, the research doesn't really say that, No, it's kind of, some show it does, some show it doesn't. And you can't bank on something like that. The supplement companies are making a lot of money off of it right now. That's for sure. But I'm with you. I don't think there's concrete 100 evidence that I would say, yes, that's going to work without a doubt.
So for the people watching, can you just touch on this quickly? I don't think we need to go too far down the rabbit hole. Can you just explain the makeup of a tendon, of tendons, and explain the disproportionate amount of collagen that is contained within tendon? This is the logic behind collagen supplementation, obviously. Yeah, they are disproportionately constructed from collagen. Yeah.
I mean,
can
just
you explain quickly how a tendon is made up for us?
Yeah, we could just really quickly, just in layman's terms, it is basically just a lot of collagen synthesis. So you have your muscle, and at the end of the muscle is a long tendon, which is, the tendon is basically this thick, it's kind of like cartilage in a way. It's like a thick collagen. And it's hard to really explain in layman's terms unless you actually opened up a cadaver and seen what a tendon is. But basically, we'll just say that it's made up of the stuff, this protein called collagens. It's different. It varies from what you see on it's not like steak. It's not meat. It's that stuff or like when you get a chicken breast, that little white piece of tendon on there. If maybe people can think of what it is there. So that's what we're talking about, is the tendons, which is made out of this stuff called collagen, which is a bundle of proteins altogether.
And then this is where my recommendation for saying, okay, so we might well consider collagen supplementation if we're dealing with tendon injury, because just by nothing more than the virtue of the makeup of the tendon, it kind of makes sense to make an effort.
Right. Yeah. Of course.
Captain Obvious.
Yeah, I get what you're saying.
I don't know
collagen. I'm not taking collagen. Yeah.
Sure. You're trying to repair collagen. Let's take in some collagen with a greater.
I was wondered is it is a protein, so is it being denatured when it hits the hydrochloric acid of the stomach and things? Is it even bioavailable after it's gone through digestion? I don't know. So that's kind of always been one of my questions.
Yep, cool. All right, so let's start talking a little bit. So we had nutrition. My lament that very often when guys get hurt, they fall off, and I think that's a mistake. Then we have a layer on top of that I would call over-the-counter supplementation. There are some things in there I mentioned, like L-glutamine, and collagen are two that spring to mind. There are some things in there that potentially you would put in there, but I would actually argue you probably have those in there on a daily basis, like creatine monohydrate and that sort of stuff anyway. Those are the two that stand out for me that you might draw in, where you wouldn't normally have them. I don't think that collagen supplementation is front of mind when the birds are singing and the sun is shining, but I think it makes sense to open that door to some degree. And then we get into what we're all here to talk about is, okay, so what is out there that potentially and plausibly, and I wanted to start the discussion with explaining how I arrive at many of my models for enhancement practices. And they are literally by, for want of a better word, looking at what is going on in the research community for anti-aging and injuries, and kind of working backwards and saying, okay, so it's not all about get big or die trying. I'm very much, interested in anti-aging and looking at what we can do in terms of, preventative measurement. Now, I'm completely open to the idea of people who say, yeah, but Victor, you've got the volume turned up to 11 and there's risk. So I have no problem with that, because that's exactly what I'm doing. Completely agree. But the underlying premise is that many of the practices that I take on board, like a little bit of growth hormone and a little bit of insulin and angiotensin 2 suppression and a little bit of clenbuterol and a little bit of androgens, a little bit of the origin point for this modeling is premised on either preventative or treatment methodologies for age-related muscle wasting, and also related diseases like osteoporosis and cognitive function decline, and so it's very much that. And I guess the first thing I wanted to lay out here was I would argue that it's plausible, especially for older individuals who are experiencing hormonal decline, that some degree of hormonal, enhancement is actually a great preventative measure for against injury. Don't get hurt in the first place is the model, I would argue,
Right.
which is fascinating because we still live in this era of judgment and taboo because you're using these products, which I think is absolutely fascinating. So I'm going to suggest for a guy who's in his mid-50s, when you come and watch the way that I train, I stand by the statement. I believe that some of the practices I employ prevent me getting injured in the first place.
Yeah.
And I would argue, I would argue as a mid-50s natural guy, I probably get hurt a hell of a lot more than I do. So that would be the first thing that I find interesting. I think that a lot of people when they have this discussion, they want to talk about PBC 157 and they want to talk about TB 500, and I think they're interesting conversations. But I think it's very much like the discussion around nootropics, and people watch the movie Limitless and they think you take a pill and you're suddenly the world's smartest man. And I would say it doesn't work that way. The beginning of the process is saying, look, there are about 8 or 9 different metabolic pathways that we have the potential to modulate. And each one of those, as long as you are moderate, there's a rational thought process to say, well, that behavior increases our preventative options here. The very nature of taking a little bit of growth hormone and taking a little bit of this and taking a little bit of that has the potential to, lower risk before risk happens, lower injury rates before injury rates happen, which again, that in my opinion that's a very difficult argument to make with the medical community, because a lot of people are just going to look at the studies and say these things are poison, they're going to kill you, rather than no, that's probably true. Like if we use androgens to treat osteoporosis, maybe there is a place in there for the use of these compounds in a preventative manner, not use them when we have a problem, but use them preemptively to ward off these age-relating disease states before they even present.
Right.
Yeah. So that would be the first thing. So, but let's jump into PBC 157 and TB 500, because these are the ones that everybody's heard of and everybody wants to know about that. So, do you have anything specifically that you wanted to talk about these two particular healing peptides? So make sure we cover any details that you wanted to cover here, Adam.
No, I mean, I've been asked just by friends in the, as you say, the tribe, who have been hurt and have asked me, and it's something I really don't, like I said, we don't learn about these things in medical school. I know the BPC 157, the gastric peptide, I know that it definitely increases bone and collagen synthesis, so that seems to be beneficial. So I guess my question would be when, and I'm sure this is a question of everybody, when would you implement it? So in your comment on Instagram, you had a guy who said he's going in for a bicep tendon repair. Is this a time that you think that would be a good time, post-surgery or something, that he would start implementing something like that? Okay. And how? So
first I'm going to ask you to explain something to people. It's fair to say if we restrict our conversation here to, as I said, there's a discussion about wound healing. There's a discussion about bone healing. There's a discussion about tendon injuries. And myself, I think there's enough difference between these discussions to hold them as separate discussions.
I would definitely agree. Yeah. So you have a wound that's made up of a certain type of tissue. So you have a muscle that has a different type of tissue. The tendon has a different type of tissue than the muscle does. And then the bone's a completely different beast on its own, so definitely.
Correct. So I think to have a meaningful discussion here, you kind of have to pick one of those things. Yeah. Right. So we could always come back and explore the others as separate conversations, but let's just pick tendons, because I think this is the common ground here, right? Like for us, yes, it's true. Like if you break your leg and, you could argue, is there anything that I can do to speed up the healing process? But that's a conversation over there. Yeah. Let's just stay within the box of tendon healing here. So the first thing I would suggest that people need to understand about tendon healing is that, and I'm going to actually ask you to explain this because you're going to do a much better job than me, but it's fair to say that tendon healing really isn't one thing. It's actually 3 overlapping phases. Can you just explain the difference between inflammatory, regenerative, and remodeling healing in the context there?
Yeah, so you definitely have, like you just mentioned, there's all these different phases of healing. So basically, right when you have the initial injury, your body kind of sends out all these certain types of, we'll just call them cells or whatever, they send them to the area to kind of kick off or initiate the healing process. So those are your inflammatory things. Everyone knows that
process.
right. So everyone knows that when you get hurt, you swell. That swelling is happening because it's drawing in all those areas. And then you have like the regenerative stage when things are kind of, you're starting to lay the building blocks down. And then you have the totally remodeling where it kind of, a new type of tissue comes in and heals over it. The problem is a lot of times is that new tissue that's being laid down, it's like a scar tissue. And it's not the same as the original tissue. Another thing that comes into play is it gets stuck in sometimes one of those phases. So it can be stuck in an inflammatory phase and it could never go on. So you have like a tendinosis or a tendonitis, which is a lot of what our tribe is dealing with, is that where they just are stuck in this type of repair that it's not fully moving on. And they're either stuck in that inflammation or the regenerative one. And they have this tendinosis, which is this chronic kind of disease of the tendon. And honestly, from my standpoint, when you open it up, when you physically look at it, you can see this is a diseased tendon versus a nice, healthy one. They get gray and slimy and gross. And so it's like you left that meat in the refrigerator out for too long. I mean, people have definitely looked at chicken and steak and things, so they know what I'm talking about.
Everyone's seen that. Yeah, correct. Okay. So the reason I say that is because I would argue that we shouldn't see things as like an injury. The first question said, well, what kind of injury is it? That's the discussion we had first. We can talk about tendons. And then you have to understand, well, there's phases of recovery and what you would deploy depends on the phase that you're in.
Right. Is it acute or is it chronic? Or
yeah, correct. And so logically, if you're dealing with the inflammatory phase, then potentially drugs that have the potential to assist us in this regard make more sense than something that you would deploy later in the healing process. So I would say, okay, so it's a little bit more sophisticated than use that, like you have an injury, use that drug. You need to kind of go, okay, so I recognize there are multiple phases to injury recovery, and simply choosing drugs that are appropriate to that phase is a huge step forward for people. It's using the right tool at the right time for an expected outcome. So I would say that where PBC 157 and TB 500 really fit into it is they are drugs that help to potentially escalate the situation where we can improve, and we're going to use layman's terms here. Forgive me. Blood flow to the area. Tendon tends to, the reason tendon doesn't heal very well, God, I feel embarrassed talking to you about this. I'm making statements. I feel the reason tendons don't heal very well, in my opinion, is principally due to blood flow to the area.
Yeah, it has a very, very small amount of blood flow. Honestly, the peritoneum, which is a small little layer around the tendon, is so small it's almost see-through, and that's where it gets most of its vascularity from. So you can imagine if you have any bit of injury to it, I mean, you can touch that thing with your finger when you open up a tendon and it will rupture. So if you have any bit of injury, the peritoneum gets destroyed. No, it doesn't have a lot of blood flow. So you're completely right. People know that, like, that kind of tissue, the same with like cartilage, like, when you get your ears pierced, they don't heal because there's not a lot of blood flow to those types of tissues. And that's just putting it in layman's terms. You're 100% correct.
Yeah. So drugs like PBC 157, that's really what they're all about, trying to improve, in layman's terms, trying to improve the capacity to get our healing nutrients to the site. Right. The analogy, and you'll laugh, but this is the analogy I try to explain to people. It's like saying, okay, so I have a beautiful block of land on a scenic coastal outlook, and I want to build a lovely house, but the only road to get in is this winding little dirt track, right? And every day, the trucks with the building supplies come, but they have to kind of line up to get in because the access to the site is poor, right? And so the process of building that house is mind-bogglingly fucking slow because there's a road that's preventing us getting the building supplies. And the best thing you could do in that circumstances would be simply do this, and that is put in a better access road. Right. And by putting in a better access road, you will more automatically improve things. But it's also true that if you don't have the building blocks coming to site, then you have a better access road with no trucks on it. So the mistake that a lot of people make, in my opinion, is they put in a better access road by looking at drugs like PBC 157, right, which is improves blood flow to a situation where we have poor blood flow. But then you have to make sure that the building blocks are following behind. if that makes sense. So I would argue that the ideal model here would be a model that takes into account good nutritional practice, protein, fats, and carbohydrates, and then you would have micronutrients, and then you would have potential supplements on top of that, and then you would potentially have drugs like growth hormone, and like, maybe we could talk about androgens, maybe we could talk about, telomere, maybe we could talk about all these other things. But what PBC does, and I think it's a really important takeaway for people, is it's the capstone. It improves access to the building site. Yeah. And so it makes logical sense that says, if you have everything else in place and all the trucks are bottlenecked at this, at this junction point, then the introduction of a drug like PBC 157 has the potential to change everything. Right?
Yeah, that's actually a really good analogy. It's literally, as you know, it's called angiogenesis.
Yeah, I'm just trying to use layman's
terms.
Yeah.
No, I was just gonna tell them that literally that means that you're laying down more vasculature in that area. So his analogy is perfect. You're literally putting more roads to that tendon.
Correct.
So, yeah,
but the big takeaway for me that I think people miss is, but what about the other shit?
Right. So if you don't have all the other stuff in place, then building roads,
building roads don't do nothing.
Anything there, right?
Correct.
There's nothing that needs to be delivered.
Absolutely. So all you've got is a beautiful 4-lane tollway with no traffic.
Right. Yeah.
Right. So this is why I think the people miss, is because they don't understand the underlying mechanisms of these drugs. They miss something. They go, literally, if you see angiogenesis, which is the term, as correct said, both, look, in my opinion, and I know this is a very simplified conversation, we can go as far down the rabbit hole as someone wants. In my opinion, both TB500 and PBC 157 can be, to some degree, viewed through the same filters, because they have enough in common to say, really, this is about angiogenesis. Really. Yeah. Is there differences? Absolutely, 100%. I would argue that TB500 tends to work better on skeletal muscle tissue injuries. Yeah. I would argue that PBC 157 works better on localized tendon issues. I think that there's an argument that you could even potentially deploy TB500, like year round. I don't actually do it. I don't recommend it, but I'm more open to the idea of doing it than PBC 157. To me, PBC 517 is an acute treatment methodology model. You get in, you use it, you get the outcome, you get out, and you leave it alone. It's not something you live on, and it's a mistake that I've seen more and more and more from the powerlifting community, things like that. They tend to view it as something that's for chronic application. I completely disagree. I think it's for acute application. And if you want to have a conversation about chronic application, you should probably lean more towards TB500. Yeah. So I know there's people out there that are going to be wanting to argue this. Please understand what I said at the very beginning. This is the opening gambit. This is the opening the door to the conversation. This is not the be all and end all of the conversation on these drugs, because I think you have to paint the picture first and say, okay, so for most people, most of the time, this is why we would use these drugs under these circumstances. So let me just try and back up a bit. So we have a tendon injury. We have at least three phases of healing. You might argue there's 4. I don't know necessarily that angiogenesis is really, top of priority when you have inflammation. You could argue that you're laying it down in preparation for the next phase. I get that. It takes time to build these roads. Fair enough. But really, I would be focusing on tools that we have in a toolbox to modulate inflammation at that point in time. And we have some excellent tools to do that. And then you go, okay, so the next phase, the next phase, the next phase. The biggest takeaway from me, however, would be that without all of the other pieces on the table, creating a nice 4-lane highway with no traffic is like, well, to what end? And right. That's not going to help. You have to have high quality sleep hygiene, stress management, high quality nutrition on the table. And this is where it leads me back to, I end up sounding like a fucking broken record half the time. I would argue that you could do most of that on a year-round basis. And then you would have potentially a handful of drugs that you might walk in and walk out if you found yourself injured, but you would have 80% of the players on the table all the time. Right. And then you end up with this really weird situation. You go, so if you were to preemptively put those players on the table and you've got 80% in play all the time, 20% that you would wheel in and out on a conditional situational use basis, then you are very likely to see a lowering of total injury rates in the first instance. And then if you just bring in the 20% of tools, if you've got everything else in place, I would argue that you'll see a more rapid response time because you have all of the building blocks in place so that increased angiogenesis actually can do something, can offer something. Yeah. So, yeah, I don't know how you feel about the conversation today, but I think there's a framework, there's a strategy kind of coming out of this.
Yeah, definitely. I think people always want to know cut and dry. What would you recommend?
How
So I
much of
guess
this?
like if there was a takeaway from this conversation, listen to you, I would say, and I think I definitely agree. Have all the stuff, the nutrition, the sleep hygiene, all of that in play already. That's going to be the bulk of it. That's going to be the most important. And then we have these other tools that we can talk about potentially, and they might not all be for the same part. Like you said, there's different aspects of healing.
Sure.
So yeah, so you need to know what kind of injury you have and where are you at in that injury before you can even or should start implementing them.
Correct.
And then there's also, we could dive into another time the preventative, like you said, doing things preventatively.
So I know very well if I don't nominate some products and some dosages, I'm going to cut flack for just basically making a motherhood.
Yeah, that's kind of what I was getting.
So I'm not going to load myself up to that. So I just want to, if I can, if you can give me a moment, some latitude here, I just want to put some potential dosages of these healing peptides on the table, because if I don't, I know.
That's what people will be waiting for.
Yeah, that's what they're going to look. So what I would argue is that if you qualify yourself, if you said, look, yeah, that's fair point, Victor, you know, that's not how people talk about these drugs. They tend to talk about them as a panacea, as a monotherapy that, you know, solves all ill wills, and yeah, you make sense of what you're saying. And we get to the point that we're going to walk in PBC 157. The first thing I would say is, in my opinion, even though, you know, we still need more data on this drug, I think that we can discuss this drug as a safe, you know, or a safer injury recovery tool. To date, it's my opinion that they haven't yet discovered what LD1 is. In other words, they haven't managed to kill anything with the drug at all, ever, with this drug. So it appears to be very safe. Yeah. The effective dose, I would argue, somewhere between, say, 200 and 250 micrograms a day, which you would inject either into the muscle or subcutaneously near the injury site 1 or 2 times a day for about 30 days. This, in my opinion, is not a drug that, if you're injecting it, you're supposed to take year round. I would say that you do it for 30 days and you take a break for a couple of weeks. And then if you wanted to repeat the treatment, great. I have no problem with that. With TB500, you could either use these as monotherapies. In other words, they're used, you know, separate to each other. You could make a very good argument that they're very synergistic. I accept that as well. As I said, TB500 works in a very similar manner to PBC 157. There are some differences, agreed, and that's the decision about why you would use which one when. I would argue that if you can afford it and if you can access it, what would make sense would be to actually use them together synergistically. They are similar but different, and different enough to use, you know, as separately. Biasing towards TB500 for musculoskeletal injury, biasing towards PBC 157 for tendon injury, and the administration of TB500, I would be saying, look, the typical dose is somewhere around 2 to 4 milligrams at the time, not micrograms, milligrams a week, again, for about a month or so. And then you would lower that dose to about 2 milligrams and follow that on as a maintenance dose, you know, once every 2 weeks or so. So I'm a little bit more bullish towards TB500 for long-term chronic use, and a little bit more, okay, PBC 157 is really, in my mind, more acute use. I do want to put up one flag, one disclaimer, if I can. Whenever you talk to people about drugs, if they can't tell you the good, the bad, the ugly, I would say be very, very cautious. You want to be able to say, so what's the ugly here, Victor? Be aware. Most of the evidence that we have in this drug at the moment is in surrogate models. Okay. I'm not really opposed to the application of research chemicals when there is no other alternative class of drug that we could easily go, that does that anyway. But this is a class of drug that is unique enough to say, this is not something else. We have an alternative. You either open this box or you don't. There's nothing else on offer. It's at this moment in time. Yeah. So it's a research chemical in that regard that makes sense. It's currently under research. It's not abandoned by the research community. It looks like it will make it into approved for human use. There's lots and lots of surrogate models. There's a few human use models. It's very interesting. It appears very safe. I haven't yet seen LD1. Nothing has died so far, like massively trying to kill. You're trying to kill an animal with this drug. They don't seem to be able to kill it. It appears to be the one thing that I would put my hand up in is I'm not sure if I had a pre-existing tumor mass, I would be introducing anything that raises angiogenesis. That would be to me, don't do that. Don't do that.
Right.
So if you have a pre-existing condition or you consider yourself to be high risk, for whatever reason, if you said, look, like I'm fucking expecting cancer any day now, right? I don't know that a angiogenesis promotion model would be top of mind.
Yeah.
I think that's fair. Yeah, I think that's fair.
Totally fair.
Yeah, cool. All right, so I think that's interesting. Is it okay if we just go through a list of things that I might potentially put on the table with those things? I
kind of wanted to ask too, would you or do you think that those two drugs are more beneficial than something like just growth hormone, which we know has connective tissue and reparative properties?
Mm-hmm.
I mean, that's been well studied for years. We know that we have more studies showing that it helps with collagen synthesis than it does actual like myofibril or muscle tissue, right?
Mm-hmm.
So would you would you put growth hormone above those?
Yeah, I think if you didn't have a choice, in other words, like either or, have to pick one, right? I would actually argue that, okay, I think I would take a small amount of Anavar, yeah, and a small amount of growth hormone as that's the first two things I would reach for. Okay. That is, maybe I'm biased by my opinions on the potential benefits of elevating protein synthesis along with, elevating growth hormone, but I would say those two are first. But then I would say, okay, so there's no reason we cannot continue to layer drugs that have different mechanisms of action, right, that appear to be synergistic, that would make sense, that have a reasonable safety profile on top of those.
Right.
So
and that's your whole model.
That's the whole model. That's how it worked from the beginning. Where, it doesn't matter whether it's hair loss or whatever. It's like literally, let's write down a list of all of the stimulatory and inhibitory inputs that we can identify that have some measure of clinical evidence to support their application, right? And ask the obvious question, what can we do about that, Doreen? And if there's a tool in our toolbox or within easy reach that we could potentially deploy here, you have to ask the question, well, why would you not do that? Like it's a legitimate question. And the answer honestly would be, to me, really simple. And that is, well, I can't afford everything. I have to make choices, right? Yeah. Right. So if that was you, if you said, look, and I hear what you're saying, Victor, you're going to do those 6 things. And I understand why you came up with that list and it makes perfect sense and you can access them. I can only afford this. I would argue that diet would be first. Some over-the-counter supplements like collagen supplement and L-glutamine would be like, hopefully you could squeeze that in. Then I would basically look at like a low dose of testosterone to maintain quality of life. I mean, literally physiological range. Don't be blasting testosterone at that point. Yeah, like 150, 160 milligrams a week, and then put a little Anavar. Anavar is a drug that has plausibly unique properties in terms of its capacity to influence the immune system. This is why I'm a big fan of this drug when you're injured. It does better than other drugs in, what I would call healing environments, like burns victims. This is the drug of choice, really. You're in. So it makes sense to go. So if we can look at that drug and say, look, that drug appears to actually do very well with people that need to elevation of immune response, and make this very clear for guys listening. Elevated applications of androgens in general have a deleterious effect on immune response. It's not positive, it's deleterious, right? Mm-hmm. So we want to basically go, okay, so we don't want to be blasting, and we want to potentially look at the drugs and say, is there any of these drugs that appears to have a more beneficial effect on immune response than any others? And the shining light is Anavar. Yeah. So that's why I would look at that. And then I would start layering the extras. Growth hormone, an anabolic that seems to lend itself towards enhanced immune response, over other choices, and then just keep layering them up. And I don't see PBC 157 as either or. I see it, well, you would put them together unless you can explain to me why you can't. And that would be, I can't get it, I can't afford it.
Right. Makes sense. I had one other question about those two. The administration. So you talked about injecting sub-Q or IM through near the area. I've seen they have both oral and nasal kind of ways. Do you know anything about the bioavailability of those?
Oh, this is hugely controversial, and I know there's people out there that will hear this that will shout me down for it, and that's okay. You know, there's some things that I'm really bullish on, and I'll stand my ground. This is one of those things that I'm going like, you know what, dude, we don't have the evidence.
Yeah, that's kind of what I figured.
So anyone that says da 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 da, I'm telling you, I've read the studies. We don't know, right? But I would argue this: the oral administration of PB317 makes sense when you're looking at the treatment of ulcers.
Right.
It's the localized administration of the drug. That's where the origin of this drug development came from, right? So if I was saying, look, I have a gastrointestinal issue, like an internal issue, I would be leaning towards the oral application of the drug. If I had something that was in soft tissue, like muscle tissue, I'd probably go with TB500. If I could do both, I would do both. And as I said, when you're talking about PB, I would still argue, even though people say it goes systemic, I would still argue that we don't have evidence to say, either way. So I would say most of the people, if you lined up 100 people that, in my opinion, have an opinion and have the right to an opinion because they've read the literature, right? I think the overwhelming majority today would still support localized administration as I do. There are absolutely...
I was probably asking more selfishly for me and my patient population. Knowing who we're talking to today, there should be no one listening to this podcast that's afraid to inject something in the area.
That's the point I'm making. It's like, what the fuck are you talking about? Like, exactly. I think the point I make though is that you can inject it anywhere you want for systemic benefit. And I would say, well, we may well get to a point where that becomes self-evident. But in my opinion, we're not yet at that point. And so what makes more sense would be to go, why can't you just try and get it close to the site? It's kind of one of those things that says, look, if you're injecting esterized hormones that have a cleavage life of 3 days before the hormone goes from a prodrug to its active form. In other words, you have to cleave the ester before the drug works. I get it. Put it anywhere you fucking want, right? But if you're introducing a drug that takes immediate effect, it kind of makes sense. It says, okay, so we probably don't want to put it in subcutaneous fat. We want to try and get as close as we can to the site of injury. Just logically, forget what evidence we have. I would argue the evidence is open to interpretation. I would say let's just do it rationally. Let's try to place it intramuscularly or subcutaneously close to the site of injury.
I like that.
Yeah, cool. Okay, so that's coming up on an hour. We just crossed over hour 7. So I think that for a first pass video for someone that doesn't really know this domain, I think that's a really good place to start the thread. Yeah.
I'd be happy if I was a listener.
Yeah. So what I'd like to suggest maybe is if we could put this out there and let people marinate on it for a couple of weeks or whatever, because I know you're a very busy man. And then I'm going to be really cheeky and say, maybe we can get you back on and we can talk about like something a little bit more specific. Let's talk about wound healing. Let's talk about bone healing. So I've broken my leg, I've broken my ankle, there's a bone that needs to be healed, and we can maybe just try and create some more siloed information that's quite specific to this injury, this event, this circumstances, this outcome.
Yeah, of course. I would 100% be willing to come back. I hope none of your listeners really have like chronic wounds and things. I hope we don't have diabetic foot ulcers and things that I see.
Where I get it from is you'd be surprised by the number of people that I've helped that have lost a lot of weight and gone and had like stomach surgery to have the fat removed, to have the skin removed. Right.
Gotcha.
So my personal hands-on experience with wound healing actually comes from people who were chronically obese, like obese, right? And they lost so much fat that they literally felt that they needed surgery. Yeah. And I found that this model is a fucking cracker. It works even people have done the surgery going, what the fuck are you doing? Because that's amazing how quickly they recovered. Yeah. So I wouldn't, my focus is very specific in that regard, if that makes sense. It's like I've had a couple of dozen people that have had that surgery, and their recovery time is just phenomenal based on that model.
Awesome.
So
Yeah.
it's kind
Well,
of,
I mean, if it's an incisional surgery, that could
yeah.
help anybody too, like your athlete, like the guy in the comments who's undergoing surgery tomorrow, getting the bicep tendon repair.
Yeah.
Same type of deal. The way that I deal with wounds most of the time, a lot of our incisions heal pretty well. We don't deal with it, but we deal with a lot of the diabetic population who their feet are rotting off the bottom.
Yeah. That's not really in my wheelhouse.
Yeah, I hope there's no bodybuilders out there that have put themselves into that bad of diabetic state.
Yeah, that's not really my wheelhouse. My unashamedly, my viewpoint is kind of like looking through a keyhole, I suppose. Like I'm just seeing a small piece of the puzzle, but it just anecdotally, it seems to work very well, and it makes sense.
Awesome.
Why would it not? And so yeah, cool.
Yeah, I'm way down to come back. I would love to. So
yeah, great talking to you, buddy. I appreciate your time. Thank you very much, and we'll look forward to seeing you again. Thank you, mate.
Yeah, thanks so much, man. Keep doing what you're doing. It's awesome. It's great for the community.
The Victor Black Masterclass presentation is brought to you by